Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 515 of our pharmacotherapy series, which majors in chronic kidney disease. This case applies to patient WKS in part 514 of this pharmacotherapy series. What are the goals of therapy for WKS's calcium, phosphorus, and parathyroid hormone abnormalities? What options are available to treat these disorders? The management objectives for patient WKS are to a. Manage serum calcium and phosphorus concentrations. b. Prevent or manage secondary hyperparathyroidism. And c. Restore normal skeletal development without inducing a dynamic bone disease, or low bone turnover. These goals are best achieved with dietary phosphorus restriction, appropriate use of phosphate binding agents, vitamin D therapy, calcimimetics, and dialysis. I will now briefly comment on dietary restriction of phosphorus. In general, serum phosphorus should be lowered toward near normal levels. The KDIGO recommends normal levels for all stages of CKD. Dietary phosphorus restriction can prevent hyperphosphatemia and maintain target phosphorus concentrations. Dietary phosphorus should not exceed 800 to 1000 mg per day. Predominant sources of phosphorus are protein-rich foods, which presents a challenge in tailoring a diet that lowers dietary phosphorus intake while providing adequate nutrition. However, efforts should be made to distinguish between organic, e.g., plant seeds, nuts, legumes, and meats, and inorganic phosphorus, e.g., preservatives and additive salts found in processed foods, sources. Inorganic phosphorus sources are absorbed to a greater extent than organic phosphorus, that is 90% versus 50%, respectively, and should be minimized in the diet. Dark carbonated beverages are a common culprit for elevated phosphorus levels. Their consumption should be discouraged, and the beverages should be removed from vending machines in dialysis clinics. Additionally, the type of organic phosphorus sources, plant versus meat, has varying effects, with plant sources associated with lower serum phosphorus levels and decreased fibroblast growth factor 23 levels. Although phosphorus is removed to some extent by dialysis, neither conventional hemodialysis nor peritoneal dialysis removes adequate amounts to warrant complete liberalization of phosphorus in the diet. Nocturnal hemodialysis is an exception where patients may require phosphate supplements because of the prolonged dialysis duration. Regular dietary counseling by a kidney dietitian specialist is necessary to reinforce the importance of phosphorus restriction and other dietary recommendations. Next we will focus on phosphate binding agents. A significant reduction in serum phosphorus is difficult to achieve with dietary intervention alone, particularly in patients with more advanced kidney disease, e.g. FR below 30 ml per minute per 1.73 meters squared. For these patients, phosphate binding agents used in conjunction with dietary restriction are necessary. Phosphate binding agents limit phosphorus absorption from the GI tract by binding with the phosphorus present from dietary sources. Therefore, these agents must be administered with meals. Available binders include products that contain calcium, iron, lanthanum, aluminum, or magnesium cations or the polymer-based agent, sevelamer. And now we will focus on calcium-containing preparations. Calcium-containing preparations, especially calcium carbonate and calcium acetate, are frequently used to prevent hyperphosphatemia in patients with kidney disease. The many preparations available vary in their calcium content. Correction of hypercalcemia is an added beneficial effect of the calcium-containing preparations. However, a risk exists of hypocalcemia and cardiac calcification associated with the prolonged use of these agents. Additionally, the higher bioavailable calcium in calcium carbonate may lead to positive calcium balance. Calcium citrate is a calcium salt with a phosphate binding capacity similar to that of calcium carbonate. However, because it also increases aluminum absorption from the GI tract, its use is not recommended in patients with kidney disease. Simultaneous administration of vitamin D preparations and calcium also increases the risk of hypocalcemia. A corrected serum calcium should be determined before therapy is started and at regular intervals thereafter. Many clinicians often correct calcium levels for low albumin. Although this practice is still very common, new Medicare quality improvements will be based on uncorrected total serum calcium levels. Calculating corrected calcium adjusts for the change in the ratio of free, unbound, versus protein-bound calcium owing to reduced serum albumin concentrations. Corrected calcium 9 mg per deciliter is equal to measured calcium, in milligrams per deciliter plus 0.8 times 94 grams per deciliter minus measured albumin in grams per deciliter. Calcific uremic arteriolopathy or calciphylaxis is characterized by calcification of the arterioles and small arteries with intimal proliferation and endovascular fibrosis. Calcific uremic arteriolopathy and manifests visually as necrosis of the skin and is most frequently seen in dialysis patients, affecting up to 5% of patients. Calcium-based phosphate binders are one of the triggering factors associated with the development of calcific uremic arteriolopathy. If the patient experiences hypocalcemia or evidence of advanced calcification, the patient should be switched to a non-calcium-based phosphate binder. Alternatives include sevelamer and cations, such as lanthanum carbonate or magnesium preparations. For patients requiring dialysis, reducing the calcium concentration of the dialysate bath may decrease the risk of hypocalcemia. Although avoiding hypocalcemia should reduce the risk of cardiac calcification, calcifications still can occur because of other contributing factors in the CKD population, e.g., hyperphosphatemia. Nausea, diarrhea, and constipation are other side effects of calcium-containing products. Because calcium-containing phosphate binders may interact with other drugs, the timing of their administration relative to other agents must be considered. Fluoroquinolones and oral iron, for example, should be taken at least 1 or 2 hours before calcium-containing phosphate binders. Importantly, If the calcium products are being used as supplementation to treat hypercalcemia or osteoporosis, they should be taken between meals to enhance intestinal absorption. This is in contrast to their administration with meals if they are being used as phosphate binders. Let's now take a closer look at sevelamer. Sevelamer hydrochloride, marketed as Renagal, or carbonate, marketed as Renvela, is a non-absorbed, polymer-based product that binds phosphorus in the GI tract. The benefit of lowering phosphorus without significantly affecting serum calcium has led to the increased use of sevelamer in patients with CKD. Sevelamer also lowers LDL and total serum cholesterol, a benefit considering the increased risk of cardiovascular events in this population. Sevelamer has a potential benefit of attenuating the progression of coronary calcification, which may be related to its LDL and total serum cholesterol lowering effects and a benefit from reduced calcium loading. The actual benefit of sevelamer on mortality is controversial. The post-hoc analysis of the Renagal in new dialysis, abbreviated as RIND, trial showed a survival advantage with sevelamer compared with calcium acetate. However, the dialysis clinical outcomes revisited, abbreviated as DCOR, trial failed to show a difference in mortality between the two agents. One explanation for the disparity in results may be the difference in the population of patients on hemodialysis between the two trials. The RIND trial included incident patients on HD, whereas the DCOR trial included prevalent hemodialysis patients who likely would have advanced cardiovascular disease. Sevelamer hydrochloride is available as 400 and 800 mg tablets. Sevelamer carbonate is available as 800 mg tablets and 0.8 gram powder packets. The phosphorus binding capacity remains equipotent between the two formulations. The starting dose is variable and depends on the baseline serum phosphorus concentration, 800 mg thrice daily with meals if serum phosphorus is 7.5 mg per deciliter. Gradual adjustments can be made at 2-week intervals, based on serum phosphorus levels. Dosing guidelines for sevelamer are also available for patients being converted from calcium acetate. On the basis of studies showing similar reductions in serum phosphorus, 800 mg of sevelamer is considered equivalent to 667 mg of calcium acetate, corresponding to 169 mg of elemental calcium. The administration of sevelamer hydrochloride to patients on hemodialysis is associated with a lowering of serum bicarbonate. This effect should be taken into account when using this agent. Sevelamer carbonate avoids the metabolic acidosis seen with the hydrochloride formulation and raises the serum bicarbonate level. Adverse reports of fecal impaction, ileus, intestinal obstruction, and perforation should caution the use in patients with GI disease. The current prescribing information recommends administering sevelamer 1 hour before or 3 hours after administration of other agents with narrow therapeutic indices. And now let's look at lanthanum carbonate. Lanthanum carbonate, marketed as Phosronol, is a non-calcium, non-aluminum phosphate binder preparation. When ingested, it dissociates into a trivalent cation with similar binding capacity as aluminum salts. Lanthanum also has been found to be as effective and tolerable as standard treatment. Both calcium and IPTH were lower in the lanthanum group. Lanthanum is mainly excreted via the biliary route, with minimal kidney elimination. Studies have evaluated the deposition and toxicity of lanthanum in the bone, liver, and brain due to concerns of lanthanum accumulation. Although lanthanum accumulates in lysosomes in the liver, This has not been correlated with increased liver enzymes or hepatobiliary adverse events in patients receiving lanthanum for up to 6 years. This is likely an excretory process through the biliary tract similar to that for iron and copper. A prospective trial of patients on hemodialysis receiving lanthanum for 1 year found minimal deposition of lanthanum within the bone and less likelihood of a dynamic bone histology compared with patients receiving calcium carbonate. During a 2-year period, patients receiving lanthanum were not found to accelerate the natural deterioration in cognitive function seen in patients on hemodialysis. Lanthanum is supplied as chewable tablets for oral administration in 4 strengths: 250, 500, 750, and 1000 milligrams. The recommended initial total daily dose is 750 to 1500 milligrams given with meals, and dosage titration up to a maximal dosage of 3000 milligrams daily based on serum phosphate levels. Lanthanum retains the same phosphorus binding capabilities irrespective of whether it is chewed or crushed into powder. Drug interactions with lanthanum include a reduction in the bioavailability of ciprofloxacin, approximate 50% reduction, and levothyroxine. The most frequent adverse events reported in clinical trials are nausea and vomiting. We will now look at iron-based phosphate binders. Sucroferric oxyhydroxide and ferric citrate are iron-based phosphate binders with proven efficacy at reducing serum phosphate levels in hemodialysis patients. The newer iron-based binder ferric citrate has the advantage of providing supplemental iron. Early studies of ferric citrate demonstrate a reduction in IV iron and erythropoietin-stimulating agent use. However, sucroferric oxyhydroxide as a chewable tablet is not systemically absorbed, thus not affecting anemia management. We will now consider other phosphate binders. Aluminum preparations are very potent dietary phosphorus binders. Although these products were once used as first-line agents to decrease phosphorus, aluminum accumulation and toxicities in patients with CKD have restricted their use. Aluminum toxicity occurs in dialysis patients because absorbed aluminum is not removed by the diseased kidney and enters various tissues where it binds to tissue and plasma proteins. Aluminum accumulation in the bone, brain, and other organs leads to toxicities such as osteomalacia, that is an aluminum-related bone disease, microcytic anemia, and a fatal neurologic syndrome referred to as dialysis encephalopathy. Treatment of aluminum toxicity requires chelation with deferoxamine. Aluminum-containing agents should only be considered on a short-term basis, up to 4 weeks. For patients with a severely elevated phosphorus, however, high-dose lanthanum may generally be preferred in these situations. Sucralfate, used primarily for the treatment of ulcers, also contains aluminum and should be used cautiously in patients with kidney disease. Magnesium agents, magnesium hydroxide, magnesium carbonate, may be beneficial, but as with aluminum, the use should be limited because at the high doses required to control serum phosphorus concentrations, severe diarrhea and hypermagnesemia invariably result. Magnesium may be considered in patients whose serum phosphorus concentrations cannot be controlled adequately by other phosphate binding agents. In this instance, a magnesium-containing phosphate binder may be added in conjunction with a reduction in the dialysate magnesium concentration in the dialysis population. These agents should not be considered first-line therapy for control of phosphorus, and careful monitoring of magnesium is warranted if therapy is started. More aggressive control of patient WKS's serum phosphorus is needed to lower serum phosphorus toward normal levels. Currently, Patient WKS is taking a calcium-based phosphate binder. Although presumably much of this calcium will be bound to phosphorus in the GI tract, a potential exists for calcium absorption. Furthermore, her serum calcium levels are in the upper range of normal not corrected. Sevelamer should be started to limit her calcium exposure and decrease her phosphorus levels. The recommended starting dose is 800 mg thrice daily with meals, titrated based on follow-up phosphorus values. Adjustments should also be considered in conjunction with vitamin D therapy. Patient WKS should be instructed to take her phosphate binder with meals. This regimen should be implemented in conjunction with a restricted phosphorus diet. Regular reinforcement of the importance of compliance is necessary because non-adherence with prescribed dietary phosphorus restriction and drug therapy is one of the most significant factors associated with treatment failure. Use of a low-calcium dialysate may also help decrease her risk of hypercalcemia. We will now progress to vitamin D, with a focus on nutritional vitamin D. Nutritional vitamin D occurs naturally as ergocalciferol, vitamin D2, obtained from dietary sources, and as cholecalciferol, vitamin D3, obtained from dietary sources and activated in the skin by sunlight in mammals, both of which are inactive precursors of active forms of vitamin D. An intermediate activation step, that is 25-hydroxylation, occurs in the liver to produce 25-hydroxy-vitamin D, also known as 25-hydroxycalciferol, which is also relatively inactive. Final activation, that is 1-hydroxylation, occurs in the kidney, yielding calcitriol, also called 1,25-dihydroxycholecalciferol, the active form of vitamin D. Thus, the response to vitamins D2 and D3 in patients with compromised kidney function can vary, depending on the degree of kidney dysfunction and the ability of the kidney to metabolize 25-hydroxyvitamin D to calcitriol. Decreased levels of 25-hydroxyvitamin D occur in the early stages of CKD, reducing substrate for producing calcitriol. Altered vitamin D metabolism that occurs in this population warrants measurement of 25-hydroxyvitamin D and supplementation with nutritional vitamin D. Oral therapy with active vitamin D, oral calcitriol, or an analog, that is oral doxacalciferol, is likely warranted only when parathyroid hormone remains elevated despite normal 25-hydroxyvitamin D levels. As the final, active metabolite of vitamin D, calcitriol, or another activated form of vitamin D, is usually required in patients with more severe kidney disease, that is CKD stages 4 to 5. Several small studies have shown that the benefits of nutritional vitamin D administration extend beyond bone and mineral metabolism. Reduction in erythropoietin-stimulating agents, doses, improved glycemic control, reduced activated vitamin D administration, and inflammation modulation are benefits observed from nutritional vitamin D supplementation in dialysis patients. Although some effects have been repeated in different studies, randomized control trials are needed to confirm these benefits. We will now discuss vitamin D receptor agonist. Let's focus on calcitriol. Administration of vitamin D receptor agonist, active vitamin D, in conjunction with control of serum phosphorus and calcium, is necessary in many patients with CKD to manage chronic kidney disease mineral bone disorder. Calcitriol interacts with the vitamin D receptor located in the parathyroid gland, intestines, bone, and kidney. It is thought to decrease parathyroid hormone messenger RNA, resulting in decreased parathyroid hormone secretion. In addition, Calcitriol stimulates calcium absorption from the GI tract to correct hypercalcemia and prevent secondary hyperparathyroidism. In order to avoid hypercalcemia, the lowest effective dose should be used, and the patient's serum calcium should be monitored at least every 2 weeks for 1 month and then monthly thereafter. Furthermore, control of serum phosphorus is critical before calcitriol is initiated, as vitamin D increases GI phosphorus absorption. Calcitriol is available as an oral formulation, Recaltrol, or IV formulation, marketed as Calcigex. Administration of calcitriol by either the oral or IV route may be based on conventional dosing, usually 0.25 to 0.5 microgram per day, or pulse dosing, intermittent dosing of 0.5 to 2 micrograms 2 to 3 times per week. Higher doses, e.g., 4 micrograms 3 times per week, are generally required to reduce parathyroid hormone secretion in more severe secondary hyperparathyroidism, that is parathyroid hormone greater than 1000 picograms per milliliter. Daily dosing of 0.25 to 0.5 microgram may be preferred in patients with hypercalcemia because this regimen primarily works to stimulate calcium absorption from the GI tract. Intermittent dosing of IV calcitriol is routine in the hemodialysis population because administration is coordinated with dialysis. In contrast, oral dosing is more convenient in patients with CKD, who are not having dialysis, and the peritoneal dialysis population. Intact parathyroid hormone and serum calcium concentrations are used to determine starting doses and dosing adjustments for calcitriol. Changes in Medicare have resulted in more outpatient hemodialysis units utilizing oral activated vitamin D therapy. Intact parathyroid hormone is the 84-amino acid biologically active form of this hormone. It is metabolized into smaller, less active fragments with activity that is not well characterized. These fragments are cleared from the circulation by the kidney and may accumulate in patients with CKD. Assays used for intact parathyroid hormone measure the intact structure as well as the biologically active and inactive parathyroid hormone fragments. Thus, proposed ranges for intact parathyroid hormone in current guidelines are based on these assays. Assays that measure only the biologically active form, 1 to 84 BIPTH, have become available, third-generation assays. When intact parathyroid hormone is measured using both methods, there is roughly a 2-to-1 ratio between the second and third-generation assay results. An intact parathyroid hormone of 150 picograms per milliliter would correspond to a BIPTH 75 picograms per milliliter. These assays correlate very well, and the third-generation assay offers no advantage over the widely used second-generation assay. Clearly, the clinician must know which assay has been used to appropriately interpret the results, establish the desired parathyroid hormone range, and correctly adjust therapy. The KDIGO guidelines vary as they recommend intact parathyroid hormone levels to be maintained within the normal limits in CKD 3 and 4. However, the CKD5D intact parathyroid hormone target range is 2 to 9 times the upper normal limits, approximately 150 to 600 picograms per milliliter. Dose adjustments of calcitriol are generally made in 0.5 to 1 microgram increments every 2 to 4 weeks in the early stages of therapy until intact parathyroid hormone and serum calcium are maintained at target levels. If hypercalcemia develops, the decision to withhold therapy or to switch to a less hypercalcemic vitamin D receptor activator must be made. Serum intact parathyroid hormone should be monitored every 3 to 6 months, and adjustments of calcitriol doses made to maintain the goal intact parathyroid hormone and to prevent hypocalcemia and hyperphosphatemia. We will now look at paracalcitol. The unique interactions of vitamin D with the vitamin D receptor led to the development of designer vitamin D analogues, which vary in their affinity for the vitamin D receptor. In the case of treatment for secondary hyperparathyroidism, some were developed to retain the suppressive effect on parathyroid hormone release while decreasing the potential for hypocalcemia relative to calcitriol. Currently approved agents for managing secondary hyperparathyroidism in the United States are paracalcitol, marketed as Zempla, also referred to as 19-nor-1,25-dihydroxyvitamin D2, and doxycalciferol, marketed as Hectorol, or 1-alpha-hydroxyvitamin D2. Doxycalciferol requires conversion to the active form, 1-alpha-25-dihydroxyvitamin D2, by the liver. In patients with secondary hyperparathyroidism, paracalcitol significantly decreases intact parathyroid hormone without significantly increasing calcium or phosphorus. Paracalcitol is approximately 10-fold less hypocalcemic and hyperphosphatemic than calcitriol. The initial dose of IV paracalcitol is 0.04 microgram per kilogram to 0.1 microgram per kilogram, that is 2.8 to 7 micrograms administered with each dialysis session or every other day. Oral paracalcitol capsules are available in 3 strengths, that is 1, 2, and 4 micrograms, administered daily or 3 times weekly. The starting dose should be 1 microgram daily or 2 micrograms 3 times weekly if the baseline intact parathyroid hormone level is 500 picograms per milliliter or less, and 2 micrograms daily or 4 micrograms 3 times weekly if the intact parathyroid hormone is greater than 500 picograms per milliliter. Some data have also suggested paracalcitol dosing based on initial parathyroid hormone levels, paracalcitol dose equal to PTH divided by 80, rather than weight as a reasonable dosing strategy. Doses can be titrated every 2 to 4 weeks based on intact parathyroid hormone values. The recommended conversion ratio for calcitriol to paracalcitol is 1 to 4. i.e., for every 1 microgram of calcitriol, 4 mcg of paracalcitol should be administered. This information is based on similar efficacy observed when patients treated for secondary hyperparathyroidism with calcitriol were switched to paracalcitol using this dosing strategy. A lower ratio of 1 to 3 also has been proposed in patients resistant to therapy with calcitriol. Next I will talk about doxycalciferol. Doxycalciferol, another vitamin D analog, is an alternative to calcitriol and has been studied in patients with CKD5D. Doxycalciferol has similar effects on parathyroid hormone as the other vitamin D analogs. However, it increases phosphorus and calcium to a greater degree than paracalcitol. Doxycalciferol is available as a capsule and IV injection. The doses were 4 micrograms IV or 10 mcg orally 3 times a week with hemodialysis. Oral and IV therapy are both effective in reducing intact parathyroid hormone levels in patients with secondary hyperparathyroidism. However, some evidence indicated that intermittent IV therapy may result in less hypocalcemia and hyperphosphatemia than oral intermittent therapy. The recommended starting dose of doxycalciferol for patients on dialysis is 4 mcg IV or 10 micrograms orally administered 3 times a week with dosing titration based on changes in intact parathyroid hormone. Vitamin D analogues offer an alternative for patients in whom persistent hypocalcemia develops with calcitriol therapy. Use of these agents is increasing in clinical practice because of the concerns of hypocalcemia and its adverse consequences. Repeated observational reports indicate lower overall and cardiovascular-related mortality rates with activated vitamin D therapy, regardless of the agent received, than in those not receiving vitamin D therapy. 2 trials also examined survival advantages among the different forms of vitamin D in patients on hemodialysis. One report indicated that receiving paracalcitol for 36 months conferred a survival advantage starting at 12 months from initiation of therapy and increased with time compared with those receiving calcitriol. Another study reported that patients taking either paracalcitol or doxorcalciferol had a significantly lower mortality rate than patients receiving calcitriol, although when adjusted for laboratory values and clinic standardized mortality, no difference was found between the products. Possible biologic reasons for vitamin D improving outcomes include its role in down-regulating the renin-angiotensin-aldosterone system and immunomodulatory properties. A prospective trial would be required to confirm a survival advantage associated with vitamin D therapy. Next I will talk about calcimimetics. Calcimimetic agents increase the sensitivity of the calcium sensing receptors, CASR, to extracellular calcium ions and inhibit the release of parathyroid hormone, lowering parathyroid hormone levels within hours after administration. The discovery of extracellular calcium sensing receptors prompted research with calcimimetic agents that allosterically modulate calcium sensing receptors. Calcium sensing receptors are located in the parathyroid gland, thyroid, nephron, brain, intestine, bone, lung, and other tissues. The calcimimetic cinacalcet is the first agent in this class to be approved by the FDA to treat secondary hyperparathyroidism in end-stage renal disease. Cinacalcet is an effective agent at reducing and sustaining intact parathyroid hormone within target concentrations in hemodialysis patients. Cinacalcet offers an additional choice of agent to lower parathyroid hormone when vitamin D cannot be increased because of elevated calcium or phosphorus. The EVOLVE trial was a randomized clinical trial comparing cinacalcet to placebo in 3,883 dialysis patients with a primary outcome of death, cardiovascular events, or hospitalizations. Patients were eligible to receive phosphate binders or vitamin D analogues in either arm. There was 7% non-significant reduction in primary endpoints in the cinacalcet group. However, issues plagued the large trial as several patients in the placebo arm actually received cinacalcet therapy. The survival benefits of cinacalcet remained undetermined. Cinacalcet is not FDA approved for use in CKD patients not receiving dialysis because it is associated with frequent hypercalcemic episodes. Appropriate treatment for patient WKS should be based on assessment of her serum calcium, phosphorus, and parathyroid hormone values. She currently has an elevated parathyroid hormone, phosphorus, and calcium. Therefore, cinacalcet should be started in conjunction with her dietary phosphorus restriction, phosphate binder regimen, and vitamin D therapy. Cinacalcet should be initiated at a dose of 30 mg daily, with dosage titrations occurring every 2 to 4 weeks to 60, 90, 120, or a maximum of 180 mg daily to achieve target intact parathyroid hormone levels. Serum calcium and phosphorus levels should be drawn within 1 week after initiation or dosage increase, and plasma parathyroid hormone levels drawn within 4 weeks after initiation of therapy or dosage adjustment. Nausea and vomiting are the most common adverse events associated with cinacalcet. Nausea is twice as likely to occur at any dose, while vomiting is more frequent at higher doses. In Phase 3 trials, 66% of patients receiving cinacalcet experienced at least one episode of hypercalcemia, serum calcium below 8.4 mg per deciliter, although less than 1% of patients discontinued treatment. The high incidence of hypercalcemia is not solely caused by lowered parathyroid hormone activity, but is also attributed to the mechanism of action of cinacalcet. It is thought that activation of calcium-sensing receptors in bone, intestine, and other tissues may contribute to hypercalcemia. Most episodes of hypercalcemia occur during the initiation of cinacalcet therapy, and slowly titrating the dose reduces the risk. Seizures caused by hypercalcemia have been reported. Vitamin D or calcium-based phosphate binders can be used to increase serum calcium levels between 7.5 and 8.4 mg per deciliter. If serum calcium falls below 7.5 mg per deciliter and is associated with symptoms of hypercalcemia and vitamin D cannot be increased further, cinacalcet should be withheld until serum calcium normalizes or the patient is asymptomatic. Cinacalcet is a strong in vitro inhibitor of cytochrome P450 isoenzyme CYP2D6. Therefore, dose adjustments of concomitant medications that are predominantly metabolized by CYP2D6 may be required. Cinacalcet is also a substrate of CYP3A4, and ketoconazole, a potent inhibitor of CYP3A4, has been shown to increase the area under the curve of cinacalcet 2.3 times. Thus, other inhibitors of the CYP3A4 isoenzyme should be used with caution in patients receiving cinacalcet. I will now briefly look at parathyroidectomy. The parathyroid glands enlarge as a compensatory response to disturbances of phosphorus, calcium, and calcitriol metabolism in patients with CKD. Timely administration of vitamin D therapy to prevent parathyroid hyperplasia is crucial as treatment with vitamin D cannot adequately reverse established hyperplasia. A parathyroidectomy is often reserved for patients with severe hyperparathyroidism with parathyroid hormone values greater than 1000 picograms per milliliter, concomitant hypercalcemia, and failure to respond to pharmacologic therapy. Parathyroidectomy can be subtotal, total, or total with autotransplantation. One of the major complications of parathyroidectomy is the early development of post-surgical hypercalcemia. Clinical symptoms of hypercalcemia include muscle irritability, fatigue, depression, and memory loss. Patients should be monitored closely after parathyroidectomy, and all patients with signs or symptoms of hypercalcemia should be treated with calcium supplementation. In patients who have had subtotal parathyroidectomy, the remaining parathyroid tissues will start functioning adequately, so the acute hypercalcemia is transient, lasting only a few days. Hypercalcemia is permanent in total parathyroidectomy and requires long-term treatment with calcitriol and oral calcium supplements, 1 to 1.5 grams per day of elemental calcium. Studies investigating secondary hyperparathyroidism management with cinacalcet report reduced rates of parathyroidectomy surgeries. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 516.